Hello and welcome to my sports medicine video lecture library. My name is Jim Moeller and I am the director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. If this is your first time joining me, I welcome you. If you're returning after listening to other lectures in the series, I appreciate that you have returned. Today we're going to talk about chronic exertional compartment syndrome. We're actually going to talk a little bit about compartment syndrome in general, touch on acute compartment syndrome as well. Here are a list of the goals and objectives for today's lecture, and I have nothing to disclose. So what is compartment syndrome? It's a painful condition which occurs when the pressure within an intramuscular compartment or compartments elevate to a potentially dangerous level. Acute compartment syndrome usually occurs after trauma, although it has been noted in atraumatic situations as well, and I will give you a couple examples of cases that I have seen of non-traumatic acute compartment syndrome a little bit later. Acute compartment syndrome is considered a medical emergency. Chronic exertional compartment syndrome is most commonly caused by athletic exertion, particularly running and distance running. It is not an emergent problem and it often takes months to make an accurate diagnosis. The pathophysiology is that pain is due to cellular anoxia. Fluid volume in the compartment increases. The surrounding fascia prevents expansion of the compartment to allow for the increased volume, leading to increased pressure. Increased venous pressure leads to a decrease in the arteriovenous pressure gradient. Arterial pressure cannot overcome the compartment pressure, and there's decreased blood flow to the exercising muscle. Reduced blood flow equals reduced oxygen delivery, and that creates pain. It also can lead to vascular collapse as the pressure continues to increase. The lower pressure vascular system will start to collapse, and again, you have less blood flow to the area. Also, you can get increased pressure on nerve tissue. When the athlete then rests, all of this is reversed and flow is returned and pain reduces. The most common locations are the lower leg, and the anterior compartment and lateral compartment are the two most commonly involved compartments, and that's a common CAQ question, is which compartment is most commonly involved in exertional compartment syndrome, and the answer would be anterior compartment. There are other ways to get to that question and answer as well. But the forearm, the thigh, and the gluteal region can also be involved in compartment syndrome. So let's look at some anatomy. We're going to start in the forearm. And just as in the lower leg, there are four compartments of the forearm. There's the dorsal compartment, the volar compartment, which is divided into both a superficial and a deep compartment, as well as a lateral compartment. Now make sure you're thinking about the forearm in anatomical position. So the volar aspect of the forearm is going to be the flexor surface, and the dorsal aspect is going to be the extensor surface. If we take one of these cross sections and look at it more closely, you can see how the forearm is divided. The superficial volar compartment includes the flexor carpi ulnaris, flexor carpi radialis, flexor digitorum sublimis, palmaris longus, and pronator teres. The deep volar compartment includes the flexor digitorum profundus, flexor digitorum superficialis, and flexor pollicis longus. As I already mentioned, the dorsal compartment contains extensor musculature, including the extensor carpi ulnaris, extensor digitorum communis, the extensor digiti quinti, supinator musculature, as well as the abductor pollicis longus. Then we get out to the lateral compartment, which is labeled the mobile wad here, including the brachioradialis, extensor carpis radialis brevis, and longus. You can see that the neurovascular structures are relatively deep, but we have to be aware of these if we are going to perform intercompartmental pressure testing, because we certainly don't want to hit these areas with the testing needle. If we move into the thigh, we have the anterior compartment, which includes the quadricep musculature, the vastus lateralis, vastus intermedius, vastus medialis, which I don't have listed here for some reason. I'll go back and correct that at another time. The rectus femoris, also the sartorius, is included in the anterior compartment. In the medial compartment, you have the pectineus, the external obturator gracilis and adductor musculature, and in the posterior compartment, the semimembranosus, semitendinosus, bicep femoris. And you can see the important neurovascular structures in each compartment as well. Here is a classic Netter drawing showing the cross-section of the thigh at various levels. And if we look a little bit more closely and then start to divide these out into our anterior compartment, our posterior compartment, and our medial compartment. When we talk about compartment syndrome, particularly exertional compartment syndrome in the athlete, we're generally talking about the lower leg. And the lower leg is divided into 4 compartments: the anterior compartment, lateral, deep posterior, and superficial posterior compartments. The musculature in the anterior compartment includes the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. The neurovascular structures include the deep perineal nerve and the anterior tibial vessels. In the lateral compartment, you have the peroneus longus and peroneus brevis, along with the superficial perineal nerve. In the deep posterior compartment, we look at the tibialis posterior, flexor hallucis longus, flexor digitorum longus, and popliteus, with the tibial nerve and posterior tibial vessels being our neurovascular structures in that compartment. And then the superficial posterior compartment includes the gastrocnemius, soleus, and plantaris, with the sural nerve being present as well. Another Netter drawing showing the fascial compartments without musculature included. And then if we superimpose the musculature directly over that area, we can see again how the anatomy divides out into your anterior compartment, lateral compartment, deep posterior, and superficial posterior compartments. So let's talk a little bit about acute compartment syndrome. Common causes of acute compartment syndrome include fracture, direct muscle contusion, reestablished blood flow after blocked circulation, crush injuries, anabolic steroid use, and the use of constricting casts or bandages. When someone is presenting with acute compartment syndrome, signs and symptoms include the 5 Ps, which are pain, pallor, paresthesias, pulselessness, and finally, paralysis. Unfortunately, not everyone presents with a classic picture, although several of these findings may be present. Oftentimes, the only significant symptom is going to be pain. On physical examination, the patient will have pain with direct palpation, pain with passive stretch of the involved compartment or compartments, a tense musculature, which is often described as wood-like. When they try to show you their strength against resistance, they'll have weakness, and this may be very painful for them. They might have diminished sensation if there is neurologic involvement. Paralysis is a late finding, and pallor is actually a fairly uncommon finding. To make the diagnosis of acute compartment syndrome, compartment pressure testing is necessary, and generally this is done with intercompartmental pressure testing. A normal at-rest pressure for most people is going to be 0 to 8 millimeters of mercury. If there is a change in pressure between the diastolic blood pressure and the compartment being measured of less than or equal to 30 millimeters of mercury, that's considered a positive test. So if someone comes in and they have a diastolic blood pressure of 70, then you would certainly expect them to have a compartment pressure of 40 or less. So if they have a 70 diastolic blood pressure and a 50 compartment pressure, that's a positive compartment syndrome measurement. If you have a person with all the right clinical findings and you're unable to measure pressure, you don't have to do testing to make the diagnosis. The treatment of acute compartment syndrome is surgical release of the compartment, and acute compartment syndrome is a surgical emergency. And here you can see a lower leg that's been opened up due to an acute compartment syndrome. and then here they are after the surgery is completed and they've been closed. A lot of times these will be left open for several days and closed secondarily. This particular case that you see here was of a patient of mine. He was a high school athlete, decided one day that he wanted to become a kicker on the football team. And so he took a bag of footballs out to the football field by himself, and he kicked multiple kickoffs, field goals from different lengths, and punted the ball hundreds and hundreds of repetitions on a single day. The next day, he went to go up the stairs at the school and had severe pain in the anterior portion of the lower leg, and he presented to my office with a compartment pressure in the anterior compartment of over 100 millimeters of mercury. I called the surgeon directly from the office, and the patient was operated on that night. A second case was a little bit more mundane. I had a patient this year who presented, she was a soccer player, and her soccer team increased the number and intensity of their workouts in a very short period of time, and she developed discomfort in the leg, which became quite severe, even at rest. And she presented to me 2 or 3 days after the onset of pain. She had tenseness to the anterior compartment and lateral compartment. She had pain with passive stretching of these compartments and pain with resisted strength testing of these compartments. Her sensation and her pulses were intact. When I checked her compartment pressure, she measured 55 in the anterior compartment, and her diastolic blood pressure was only 65. So there's only a 10 millimeter mercury difference between the diastolic blood pressure and the compartment pressure, and she was operated on the following day. Let's talk about chronic exertional compartment syndrome. Is it chronic, or is it exertional, or is it both? Most typically, it's associated with sport activities that include running, and particularly distance running. So cross-country runners, track runners who run the distances, soccer players, military recruits. But I have seen it in athletes of various sports, including those that don't do long distance running. They're more short distance, sprint type running, jumping athletes, and so on. It can be seen in more sedentary individuals as well. The history is that of atraumatic lower leg pain, worse with exercise and improved with rest. It's described as aching, cramping, or burning, and the timing with exercise is often very predictable. So they get working in their exercise activity, and 15 to 20 minutes in, let's say, they start to develop pain, and the pain will go away when they get back to rest. This is different from someone with a stress fracture who often has pain immediately on the onset of their activity, and the pain tends to worsen as the activity progresses. Certainly doesn't go away until they stop, but it happens early on. Or someone with a shin splint or a medial tibial stress syndrome periostitis situation where they may have some discomfort early on, but then as they continue to work out, they may start to have reduction of their discomfort and get kind of a grace period where they can exercise with limited discomfort. The pain is often generalized, but can be to a specific or particular compartment. Numbness and weakness may be associated complaints, although it's unusual, but some people will develop a foot drop type of situation while they're exercising, and the problem is bilateral in roughly 75% of cases. On physical examination, you may be disappointed because they're often normal at rest. So you want to look for very particular findings that would make you think of acute compartment syndrome, but you also have to think about other possible etiologies of lower leg pain. Any athlete who comes in with lower leg pain thinks they have shin splints, and shin splints, there's no great consensus on what that actually is. But stress fractures, muscle strain, vascular compression syndromes, nerve compression syndromes, DVTs, lumbar radiculopathy, bone tumor, all of those things could cause lower leg pain. So you have to be astute with regards to your history and physical examination. But again, at rest, that exam may be normal in the chronic exertional compartment syndrome setting. Therefore, examination after exercise could be helpful if you have the ability to exercise the patient at the office. at which point you may find tenseness of the involved compartment, pain with passive stretch of the compartment, numbness and weakness, something that's more consistent with what you would find in an acute compartment syndrome setting. When you have someone who presents with lower leg pain and you're considering this diagnosis, diagnostic testing is important, primarily to rule out other pathologies. X-rays, bone scans, MRI scans can all be used because remember, common things are common. And so runners who come in with shin pain will often have stress fractures or periostitis, medial tibial stress syndrome. They may have muscle strains. The less common things, including the vascular compromise issues and the neurological problems, can also be found. But again, common things are common. You want to make sure you rule these things out. When these other problems have been ruled out and you're thinking about chronic exertional compartment syndrome, the next step to diagnosis is measuring compartment pressure. Now, before we move on, I do want to talk about treatment for just a moment, because what I do in my practice is if I suspect chronic exertional compartment syndrome clinically and other etiologies have been appropriately ruled out, I offer conservative treatment prior to compartment pressure testing. The reason I do this is that unless they're ready to have surgery for their compartment pressure problem, there's really no reason to acutely figure out what the numbers are. Conservative management is very safe management. And if they get better with conservative management, we don't ever have to stick needles in their leg to find out what the compartment numbers are. If they fail that, then we can go back and do the testing at that point because they've already failed conservative management and we know they're already a surgical candidate. And so my way of going about things is if I'm suspicious at a high level for exertional compartment syndrome and I've ruled out other etiologies appropriately, I offer them conservative management before testing. Those conservative measures include avoidance of pain-provoking activities, icing, anti-inflammatory medications, stretching, massaging, strength activities, with or without orthotics if they have foot biomechanical abnormalities. A systematic review was performed and reported in 2016 in the journal Current Sports Medicine Reports. Dr. Rajasekaran, I apologize if I mispronounced the name, and Dr. Hall, physical medicine rehabilitation doctors, looked at 7 studies that reported on the non-operative management of chronic exertional compartment syndrome. These studies looked at a variety of treatment options, including massage, alteration in gait, botulinum toxin injection, and ultrasound-guided fascial fenestration. Now, since ultrasound-guided fenestration is an invasive treatment, I would recommend only using that after compartment pressure test confirms the diagnosis. So we'll discuss that in a few minutes because, again, what I want to talk about right now are the conservative measures that I would recommend prior to compartment pressure testing. According to the systematic review, if you looked at massage, which only was one study, the use of massage did increase time to pain for athletes as they continued their exercise program. It also decreased post-exercise pain in those people, so it can be helpful. Gait alterations was examined in 4 studies with 26 patients, and that had mixed results. Changing from a heel strike running pattern to a forefoot running pattern may be beneficial. The study with the best outcomes tested pressure changes in asymptomatic volunteers, however. Now again, because ultrasound-guided fenestration is an invasive treatment technique, as is the use of botulinum toxin, we'll save those for just a little bit, because what I wanted to focus on was the very conservative, non-invasive management of someone with suspected chronic exertional compartment syndrome, which again, I recommend we partake in that treatment program prior to sticking needles in their legs to look at the compartment measurements. So now let's say that we have a patient who presents with lower leg pain and the history is suspicious for exertional compartment syndrome. The physical examination is also suspicious, that we have done appropriate diagnostic testing to rule out other etiologies, and the patient has tried the non-operative, non-invasive, conservative management strategies for exertional compartment syndrome without any benefit. At this point, I would recommend testing of the involved compartments. The gold standard testing is intercompartmental pressure testing with a device such as shown here. The setup you see here is a single stick setup. You can also do indwelling catheter placement. The most widely referenced study that gives us numbers for the diagnosis of exertional compartment syndrome is the Pedowitz study seen here, where we expect a compartment pressure of less than or equal to 15 millimeters mercury at rest, less than 30 1 minute after exercise, and less than 20 5 minutes after exercise. And again, we should consider this testing when non-invasive conservative management fails in the face of a patient who has significant findings consistent with exertional compartment syndrome. The reason we want to delay this if we can is because this test is not without risk. Bleeding, infection, nerve injury, and even causing an acute compartment syndrome are all possible. I won't get into the specifics of the test itself. Suffice it to say that I have the patient come in and we test baseline at-rest pressures. And if they have normal pressures, then I take them to our exercise area and put them on a treadmill, and we run them at a significant pace and with elevation of the treadmill in order to create pain in their lower extremity. After they've stopped the run, we repeat testing at 1 minute post-run and 5 minute post-run in the compartments that were normal at rest. If they have an abnormal compartment at rest, I don't continue on testing that compartment because once it's positive, it's positive. If they have a positive test at 1 minute, we don't retest that compartment at 5 minutes either. If you're interested, you can look at videos that show actual compartment pressure testing on various platforms on the internet. Again, the reason I try to avoid performing this test until it helps us make the decision on surgical consultation or not is that it is invasive and there are risks involved. But what about testing that doesn't have this risk? Are there non-invasive tests of compartments that may be of benefit? There is a test called shear wave elastography, which is an ultrasound test of muscle stiffness that's non-invasive, which may be helpful in the future. Studies are still ongoing looking at the correlation between the shear wave elastography readings and intercompartmental pressures. And so we still need more data to know if there is a direct correlation between these two things. It's a costly procedure, and one of the problems is it can really only be measured in one compartment at a time, and it takes about 10 to 20 minutes to obtain a result. And so if you have a patient with multiple compartments that need to be tested, you may have to test them for the one compartment and then put them back on a treadmill and retest them for the second compartment separately, and so on. Also, there can be a great deal of variability based on how the test is performed. In fact, it's best to have an apparatus set up so the ultrasound probe is up against the patient's compartment being held by some type of mechanical device, so an operator cannot change the pressure that they're applying to the compartment itself and therefore change the reading. So there's a great deal of opportunity for human error unless you have a mechanical setup to hold the probe in place. So now we have a patient who presented with lower leg pain with a history that's consistent with, or certainly suspicious for, chronic exertional compartment syndrome. They have an examination which is certainly suspicious as well. Diagnostic testing has ruled out other etiologies. We have tried conservative, non-invasive treatment options for exertional compartment syndrome, and this has not helped the patient whatsoever. And now they've undergone testing, and we have found that they have chronic exertional compartment syndrome by intercompartmental testing findings. So what's the next step in treatment? We need to start thinking about invasive types of treatment. So let's go back now and talk about botulinum toxin injection as well as ultrasound-guided fenestration, and then we'll get on to surgical treatment. So let's look at a study that was performed in France and published in the American Journal of Sports Medicine. This was a retrospective study. Patients who were tested for chronic exertional compartment syndrome were potentially included in the study. After their testing was performed, if they were positive, they were given the option for Botox injection as a treatment option for their disease process. Patients included in the study received Botox injections and then had repeat testing done somewhere between 3 and 9 months later. The average time was 4.4 months. What is graphically depicted here is the timeline of the study. So a patient had symptoms for a mean time of 40 months. As I talked about before, it can take a long time to figure out whether someone has chronic exertional compartment syndrome. They presented to this clinic, and it was determined that they had high suspicion for chronic exertional compartment syndrome, at which time a compartment pressure test was performed. As you look from left to right, that's the person jogging. The first person jogging is having their compartment pressure test. The open arrow and the hatched arrow are actually the test itself and the clinical data being gathered. And then the syringe that you see is the time of the Botox injection into the involved compartments. 1 month after the injection was performed, clinical follow-up was performed. And again, 3 to 9 months after the injection was performed, clinical follow-up as well as a repeat compartment pressure study was performed using treadmill running as the exercise exertion challenge. There were 16 patients who were studied for anterior compartment involvement with 25 compartments involved, and there were 12 patients studied for lateral compartment involvement with 17 compartments involved. You can see from the graphic that intramuscular pressures were measured at 1 minute and 5 minutes after the running test. So if we look at the pressures in the anterior compartment at the pre-Botox injection study and at the follow-up study, this is what we see. There was a significant reduction in anterior compartment pressure 1 minute after exercise and 5 minutes after exercise in the study group. The 1 minute post-exercise reduction was statistically greater than the 5 minute post-exercise reduction. Well, what about the lateral compartment? This also showed significant improvement where the 1 minute post-exercise reduction was significantly greater after the Botox injection, as was the 5 minute post-exercise reading. On the clinical side, 15 patients reported complete resolution of their pain with exertion, which certainly is a good outcome. Also on the clinical side, however, there was a decrease in strength noted in 11 patients, where on average the strength went from 4.5 on a scale of 0 to 5 down to 3.5 in 11 people. The way that this affected the patient was not actually described in the study. And certainly there are additional case reports, both from civilian and military sources, which also show benefit, but these are very small single case studies. If we talk about ultrasound-guided fenestration of the fascia of the involved compartment, I was able to find a single case report on an 18-year-old female who had exertional compartment syndrome, and an 18-gauge needle was used to fenestrate the fascia of the involved compartment. This patient was able to return to her full athletics and was symptom-free at 18-month follow-up. So now let's say that we have our clinical picture that we've discussed a couple of times here, and the patient is still no better. I often don't go on to the Botox. I don't actually do Botox injections for this problem. I don't do the fenestration. So if I have a patient who I've taken through conservative management and have made the diagnosis of exertional compartment syndrome, I typically send them to an orthopedic surgeon to talk about fasciotomy. This treatment has a high rate of success, but also carries with it the greatest risk. In a study published out of the United Kingdom in the European Journal of Orthopedic Surgery and Traumatology, 109 patients who received fasciotomy for chronic exertional compartment syndrome were reported on, and these patients gave both pre and post-surgery pain ratings. Of the 109, 48 gave this pain rating by visual analog scale, and 61 reported by a verbal rating scale using low, moderate, or high as their verbal responses to their pain. The verbal rating scale was also used for activity levels, and I couldn't see from the paper that no was one of the options, so no pain or no activity. The pre-op activity scale was only recorded in 55 patients, and a post-op activity scale was reported in 79 patients, so that can skew the data a little bit as well. The first thing we're looking at here is compartment pressure along the vertical axis and the preoperative pain by visual analog score, with 0 being no pain and 10 being most painful, along the horizontal axis. And what you can see is a linear correlation. The higher the compartment pressure, the greater the pain. If we look at pre and post-op visual analog scale scores, we see that the preoperative pain score in the anterior compartment and the posterior compartment were both around 8.5 on a scale of 0 to 10. And in both cases, the postoperative score dropped well below 1. This was a statistically significant improvement in pain. If we then go and look at the verbal rating scale scores for pain and for activity, and this graph is a little bit more difficult to look at and interpret on first glance, so let's walk through it a little bit. All of the gray bars are preoperative scores, and all of the open bars are postoperative scores. If we look at preoperative pain, and remember there were 61 patients where this was recorded, all preoperative pain was either rated as high, 44 of the 61, or moderate, 17 of the 61. On the postoperative side, there were no high ratings anymore. 4 patients reported moderate pain, and 57 reported low pain. Again, I could not see that there was an option for no pain. If we look at the preoperative activity scores, all patients reported either low activity, 48 out of the 55 rather, or moderate activities in 7 out of the 55. Remember, only 55 patients had the preoperative activity scale recorded. So none of them reported high activities pre-op. In the post-op activity group, 3 still reported low activities, 55 reported moderate, but 21 patients now reported high activity levels. So again, that would be an improvement. It's hard to know though, because there's a difference in the number of people pre-op to post-op, and we don't know specifically what the post-operative findings of the original 55 were. In general, the majority of patients reported either reduced pain and or increased activity level. What I have here for you is a slide showing a scar from fasciotomy that was performed for chronic exertional compartment syndrome in one of our former Olympic long track speed skaters from several Olympiads ago. And what you can see, aside from the scars, you can see how the compartment tends to bulge out in the picture on the right, because again, you don't close the fascia back up. You open the fascia and then close the tissues over top, and so it releases the pressure, but it does allow for a bulge to occur. It has been noted that patients with anterior and anterior along with lateral chronic exertional compartment syndrome releases tend to do the best, with 80% having significant improvement and 80% returning to their prior sport level. Less than 20% have recurrence of pain. This can be increased based on technique. There is a single incision technique and a 2 incision technique. Both of those were shown through the course of the talk. With the 2 incision technique, the fascia opening has to be completed under the skin surface. The proximal and distal extent of the fasciotomy also can play a role in the long-term outcome after surgery. And certainly we have to be extremely cautious of neurovascular structures during the course of the surgical procedure as well. So patients tend to do very well. Many return to their prior level of sport, but at what time? A study published in 2014 out of the Ohio State University Department of Orthopedics looked at this question. The sample size was quite low, only 13 patients with 7 females and 6 males with a mean age of 19.7 years. The range was 17 to 24 years. 11 patients had a 2-compartment release and 2 patients had a 4-compartment release in this group. It was found that those who had a 2-compartment release, the anterior and lateral compartments, because again, those are the top 2 compartments involved, had a mean time of return to sport of 10.6 weeks, where the mean time of return to sport in those with 4-compartment release was about a month longer. So let's recap. Acute compartment syndrome is a medical emergency. Though most common in the lower leg, chronic exertional compartment syndrome can occur in many areas. Remember that common things are common, so rule out the common things. And consider conservative measures for possible chronic exertional compartment syndrome prior to intercompartmental testing. Again, that's the way I do it. It's not the only way. It's not necessarily the best way. It's just my way, so I want to make sure that I'm clear about that with you. And finally, surgery is needed for most patients with lower leg chronic exertional compartment syndrome, though botulinum toxin injection is showing promise. So I thank you for joining me today on this discussion of chronic exertional compartment syndrome. I hope you enjoyed it and I hope you learned something. If you did enjoy it and found it to be helpful, I invite you to check out the other video lectures that I have available. You can check with your fellowship director for links, and if it's met with good feedback, we may go ahead and make these public and searchable as well. But again, thank you for your time and have a great day.